cover a few topics that have already been discussed. So the first questions for us clinicians is that 90% of hepatocellular carcinoma arises in cirrhosis in Western countries at least. And so I will deal only with this type of lesions because for the other ones, nearly always we need finally to have a biopsy. So the first question is, this arises in cirrhosis as it has already been presented. Shall any new lesion be considered lesions of neoplastic nature? What else they can be? This is a series of nodules studied on liver explants, and as you can see, the large majority was malignant, but there were also high-grade dysplastic nodules, macroregenerative nodules, and hemangiomas. And you see that the lesions were between 5 millimeters and about 3.5 centimeters. If we study instead of explanted livers lesions that were detected by conventional ultrasound, we see that if we consider lesions which are between 1 and 3 centimeters, 83% or about 80% were HCC, whereas if we consider smaller lesions between 1 and 2 centimeters, 67% were HCC. So it depends on the size. But this is the main topic of our discussion. The problem is to diagnose HCC between small nodules. When there is a 5 or 6 centimeters nodules in cirrhosis, the likelihood that this is malignant is 99%, regardless of the imaging technique. So we can diagnose it, but usually this is not the problem. The problem is we have a small lesions, 5 to 13 millimeters. What is it? It might be malignant, but it might also be something else which is totally benign. And we all know that when we look at these lesions, we have no possibility to ascertain whether these are malignant or not. All of them were confirmed by histology, and you see that also the light is poor. Maybe is it possible to bring the curtains down to the top, to the bottom? This lesion was completely benign, and this slightly hypoechoic lesion was malignant. So, what can help us, and Thomas already introduced this topic before, to make diagnosis? We should consider that the 90%, as my colleague before showed, 90% of the lesions go along a multi-step carcinogenesis pathway. It means that they don't start as malignant, but they become malignant. Also, this pre-malignant lesion may be challenged, but in our opinion, there is a progression from pre-malignant to malignant lesions. And so all these possible stuff that have been presented, the near totality can be seen not even on biopsy, but on the whole resected specimen, which is for us meaningless because we need to know the diagnosis before we have any possibility to have the nodule. So we should stick to neoangiogenesis. And in these regards, the most interesting studies were those provided by the Japanese author who performed CT arterioportal angiography. What does it mean? That they put a catheter in patients who were going to be resected, so they knew what exactly were at the end because they had the whole nodule. They put a catheter in the femoral artery, they went into the hepatic artery, injected the contrast, and made a CT scan, which means that the liver is perfused only by the hepatic artery, then removed the catheter, put it in the splenic artery, and injected again. It means that from the splenic artery, the contrast media goes into the spleen and comes to the liver through the splenic vein and portal vein, and so they could ascertain what exactly was the appearance only in the portal phase. And by doing so, they could show that the progression from larger regenerative nodules, low-grade dysplastic nodules, high-grade dysplastic nodules, early hepatocellular carcinoma, well-differentiated in classical hepatocellular carcinoma, you have a progressive decrease of the portal supply and a progressive decrease of the normal arteries, and as soon as malignancy starts, you have an increase of neoangiogenesis. What is the problem then? If you look at this, everything is clear and diagnosis can be made by imaging. The problem is that we cannot perform CT arterioportal angiography in any patient. It is too expensive and it is invasive. So if we think about our methodology, we are able to detect hypervascularization only when the nodule has more arterial enhancement than the normal parenchyma. So it means that we should not have neoangiogenesis, but we should have a neoangiogenesis which overcomes the normal arterial supply. And the other problem is that when we look at portal supply, we are not able to separate portal supply from arterial supply. So it means that this bar is more or less as long as this one. So even in this case, we don't see much portal washout, but only when we go to classical hepatocellular carcinoma. And the other message that we must speak from these images is that there are cases in which there is already neoangiogenesis, but this is not more than the normal hepatic arterial supply, and these are the malignant nodules that we call hypovascular or pseudo-hypovascular because they are not poor vessels, but they don't have the arterial enhancement. So bearing in mind these points that were known since the 90s, the first international conference on hepatocellular carcinoma, which was held in Barcelona in the year 2000 and published in 2001, published the guidelines that Thomas Albrecht has already shown you, which correspond to the fact that for the first time it was established that nodules which were more than 2 centimeters in diameter could be diagnosed as HCC if they had signs of this neoangiogenesis of arterial or arterial hypervascularization, which meant they should have hypervascularization at MRI, CT, or angiography, or there was one of these techniques together with alpha-fetoprotein. Among the techniques that were able to provide such a diagnosis, at that time it was included also Doppler ultrasound. But as you can see here, there is not CIUS. Why not? Because this is what we can detect by Doppler ultrasound. At that time, CIUS was not there because it was a newborn technique. The first articles were published exactly at the time of the meeting, and real-time contrast enhanced technique was introduced in Europe only a few years later. But as soon as it was introduced, we were able to detect some typical patterns, which are represented by arterial hyperenhancement, whose degree might be only slight or more intense. And in the late phase, we have loss of this hyperenhancement, which might go to hypoenhanced, clearly hyperenhancement, or isoenhancement. If we want to stick precisely to the terminology, we should name only this pattern as washout in the late phase. Although we can discuss it later, when we talk about CIUS, we do not apply vascular pattern to lesions that cannot be seen on baseline, as it often is with CT, but we apply vascularization to lesions that are already there. So the risk of false positive results is very small, might be negligible. So even this pattern has some relevance, but let's see some examples. Just see that here there is a tiny enhancement, but in this case we had a subcapsular nodule. You see that these ascites. It is impossible to get any information with, about this nodule. If you have to decide whether this patient has to have priority for liver transplantation or not because of malignancy, you cannot make a biopsy. There is ascites, it is subcapsular, so you need a non-invasive diagnosis. A Doppler ultrasound is difficult to pick up in these moving nodules, but if we move to contrast enhanced ultrasound, you see 4 seconds after the injection, 15 seconds, it clearly enhances. In the arterial phase, there is a feeding artery, and so even though very skilled operators might pick up typical Doppler signals here, it is very difficult, and you need to be very skilled. Whereas in this case, I can say even operators who are, and this is the typical feature. This is another case, slight hypoechoic lesion, and when we go with contrast enhanced ultrasound in the arterial phase, it clearly enhances, and this is hepatocellular carcinoma. This is the same lesion as it can be seen with CT. You've seen before what the Japanese author have shown us. This is a case that was a candidate for liver transplantation. He had 4 nodules in hepatitis B, All the remaining 3 nodules were high-grade dysplastic nodules, so there was no indication to put him on the list. And he had these nodules, which was isoechoic with contrast ultrasound. So at that time point, he should be somewhere around here, and he was not put on the list. But just 2 months later, he came back, and you can see that in the arterial phase, 30 seconds, even though it is dark here, you can see there is a tiny enhancement. And based just on this enhancement, we put this patient on the list, and there were no possibility to treat him because he has severe portal hypertension, so the surgeon did not want to resect him. We attempted portal chemembolization, but he had a problem with the artery, anatomic problem, and it was impossible to embolize him. So we could follow the natural history. At that time, there was a tiny enhancement, but 8 months later, when he was still waiting for transplantation, the nodule has increased, and you can see how also the vascularization had increased. And this well resembles what happens along the natural history of these nodules. And when the lesions can be seen well, you can pick up also very tiny nodules. This lesion was treated by chemembolization. There was a small nodules here. We wanted to look if this was a satellite nodules, but we pick up 2 other lesions, just tiny lesions. So under very favorable condition, it is possible to pick up this typical appearance of hyperintensity, hyper-enhancing lesions also in tiny nodules. And the superiority of contrast and ultrasound in comparison to color Doppler, which was the technique accepted by the guidelines in year 2001, was shown by this series from our group, where we could, in comparison to typical nodules at CT, we could show that with CUs we have practically identical results when the nodules are larger than 3 centimeters, but that the sensitivity is also very good in small nodules and even in very small nodules where color Doppler is relatively insensitive. So at present, contrast ultrasound is to be preferred in comparison to color Doppler. If you remember, we can have sometimes hypovascular lesions, also in the arterial phase, which correspond to these sort of lesions. This can be seen very well with arterial portal angiography, but occasionally they can be seen even with percutaneous angiography. You see that in the arterial phase, this lesion is hypo-enhancing, where it becomes isoechoic in the late phase. These lesions should be biopsied because we don't know what they are. I go back to the slide here. They can be either early hepatocellular carcinoma or low-grade dysplastic nodules, so we don't know what they are. In this case, it was impossible only because it was just beneath the heart here. And she was an old lady, not very well cooperating. But Thomas already mentioned that in year 2005 there had been an update of the guidelines, and this update was brought in with regard to the portal washout. It was published in Hepatology, this consensus of the American Association for the Study of Liver Disease, and it deals mainly with the appearance at washout. Why was it considered important? First, we shall read what the guidelines say. If the lesion shows arterial hypervascularity, and this was already present in the previous guidelines, but washes out in the early or delayed venous phase, only a single imaging modality is required for diagnosis. So if the nodules were under surveillance, it was not there, and it appears during surveillance, it is larger than 2 centimeters, then it is now considered that if there is washout, even one single modality is enough for diagnosis. And what is also important is that in the American guidelines, and they do not have registration for using contrast ultrasound on the liver, but they state the contrast and ultrasound indicate they state that it can be used also with dynamic, it's said dynamic ultrasound, and these include contrast and enhanced ultrasound. Why was washout so pointed out? Because in the United States, since the year 2002, there was an update of the rules for allocating patients to liver transplantation. And if a patient has a hepatocellular carcinoma, it gets priority. But they did not stick to the guidelines of the European Association. They just performed CT and classified as hepatocellular carcinoma any hyperenhancing lesions in the arterial phase, regardless of the late phase. And at the end, it came up that 15% of the patients transplanted for hepatocellular carcinoma did not have hepatocellular carcinoma. So in order to make this technique more specific, they introduced the requirement of having washout, because as Thomas already showed, vascular alterations can appear as hypervascular in the arterial phase, but they do not wash out, whereas tumors do wash out. But this is important for CT, because they don't see the nodule in baseline. With contrast ultrasound, we see the nodule, so the risk of misdiagnosing a fistula for a nodule is negligible, because we see the nodule as the first time we put the probe on the body. This was for nodule over 2 centimeters. For nodules between 1 and 2 centimeters, it is accepted to make diagnosis if you have 2 techniques, not only one, with hypervascularity in the arterial phase and washout. And you see that it is accepted either with CT scan, contrast ultrasound, or MRI. And to us, it was astonishing that they accepted contrast ultrasound in the United States. What is important, you never should forget that if the findings are not characteristics or the vascular profile is not coincidental, the lesion should be biopsied. So we have a positive diagnosis. We can say that this is malignant, but we are not allowed to say by imaging technique alone that this is not malignant. So it's positive value, but not a negative value. If the techniques are negative, we need a biopsy. This is a slightly hyperechoic lesion, isoenhancing in the arterial phase, isoenhancing in the portal phase. And so this nodule, we cannot say whether this is benign or malignant. We need biopsy. And indeed, this was a non-malignant lesion. However, we should recognize that for detecting washout, contrast ultrasound is inferior to CT and to MRI. And this probably relies on the vascular properties of the contrast agent, because this is a pure vascular contrast agent, whereas MRI and CT do diffuse a little bit out of the vessels. And so we should recognize it and be aware that not seeing the washout does not, again, exclude malignancy. Another problem is that with contrast ultrasound, the judgment on the washout is rather subjective, because the washout is really very slight. And in this regard, I hope that quantification modalities may help us to make diagnosis. Because here, I think if we all make a judgment, some of us will say that this is aechoic, others will say this is hypoechoic. But if we take the whole nodules and quantify it, we can see that in this case, there is washout, and so we can stick to the guidelines and say that this is typically a hepatocellular carcinoma. But we know that in addition to hepatocellular carcinoma, we might have other lesions, and this might be hemangioma. If there is a centripetal filling in, we are able to use CUs also to make diagnosis of hemangioma, whereas if the pattern is of persistent isoechogenicity, then this resembles also dysplastic regenerative nodules, and so we need biopsy. Very seldom it happens that a nodule biopsied results to be a hemangioma, but this is a possibility. Metastases in cirrhosis are very, very rare, and what characterizes them is to be very dark in the late phase, as it happens in the normal liver. So, should we biopsy? Is it true? Why should we biopsy? In cases that were negative at both CUs and CT, which were 14 cases out of these 72 nodules in our series, 1/3 of the cases were hepatocellular carcinoma. So this is to stress again that negative imaging techniques do not exclude malignancy in cirrhosis, in small nodules. CUS is also useful to characterize portal vein thrombosis. This patient had been treated with local ablation here, and 1 year later he developed this small mural thrombosis. Is it malignant or not? This is completely different. It changes the prognosis completely. And contrast ultrasound is perfect to this task. And there have been articles demonstrating that it is better than CT. You see that at 18 seconds you don't see any contrast yet, but a few seconds later there is contrast ultrasound within the thrombus. So this is not a fibrin thrombus, it is a malignant thrombus, and the patient is classified as advanced stage. So in conclusion, real-time contrast ultrasound is an extremely useful technique for the characterization of liver nodules in cirrhosis, achieving a very high positive predictive value for the diagnosis of the hepatocellular carcinoma. But I want to stress it again, not a similarly high negative predictive value. And in our opinion, and according to the guidelines, CEUS has no significant role for detection, but only for characterization. Then a few slides only for cholangiocellular carcinoma. The pattern is exactly the same that we see in malignant disease. It is characterized possibly by a hyperenhancement in the arterial phase, but occasionally there is no enhancement or it is inhomogeneous, but it should wash out in the late phase. And this is not typical for cholangiocellular carcinoma. It's typical only of malignancy. So in a case like this one, hypoechoic lesion, slight hyperenhancement, wash out in the late phase. Similarly to this one, wide lesion, hypervascular, with washout in the late phase, believe me. We needed to biopsy the lesion to establish the diagnosis of cholangiocellular carcinoma. Central cholangiocellular carcinoma usually is very clearly depicted. If you have any question whether this is endoluminal biliary material, but this is difficult to believe in these cases, but you can perform CEUS to confirm that this is tissue, it is perfused, and as you can see here, there is perfusion within this echoic material, so this was confirmed to be malignancy inside the liver. So I have no further information. I just take 30 seconds to invite any of you who is interested in clinical hepatology to the second joint workshop that we will organize during the meeting of the European Association for the Study of Liver Diseases, which this year will be in Copenhagen on the 22nd of April. And this year will deal with liver ultrasound for the hepatologist, update on ultrasound-guided intervention and diagnostic perspectives. And if any of you has the chance to come again the next year at this same course on some additional topics, which will be liver, biliary, but also pancreatic and gastrointestinal disease, we will have the Euronso School in September, which still is a time of warm climate in Bologna, and we will come to join us in Bologna.